Morning, everyone. Like Bernardino said, my name is Luis Pimentel, he, him, él. I am with Lane County Public Health. I'm the Alcohol and Substance Use Prevention Program Coordinator. So I'm lucky enough to kind of just introduce the middle part of our agenda and presenters. So the next presenter that we have is Clair Raujol. She's a proud Portland native and lover of our state. Over the past dozen or so years, she has worked across multiple domains within the prevention field. From her time with a local nonprofit doing direct service, where she received her Certified Prevention Specialist certification, to her work now as the supervisor for Multnomah County's Behavioral Health, Wellness, and Prevention team. She has worked primarily in substance use and problem gambling prevention, but is learning more about suicide prevention and post-vention response planning in her newest role. And she is currently one of the co-chairs for the Oregon Coalition of Prevention Professionals. Claire is passionate about creating environments where Oregonians can flourish into their best selves. Outside of work, she lives on a small hobby farm just outside of Portland where her family raises beef, cattle, and flocks of chickens and ducks. If you're ever in a virtual space with her, prepare to hear the roosters crowing. I can attest to that. She feels incredibly lucky to spend the day within the vibrant city culture while escaping to the quieter farm life in the evening. And Claire.
Okay, gonna have to move this. Can everybody hear me? If I stand right here, you can hear me but not see me, right? Perfect. Okay. So thank you, Luis, and thank you, Bernardino, for inviting me to present today. Bernardino asked me to talk specifically about the Strategic Prevention Framework, which is a framework that unifies a lot of our work in primary prevention. And I started to do that, and I started to create a presentation, and then I thought, I've been in the prevention field for a while now. I have a lot of different colleagues, and there's a lot of different frameworks. We're talking a lot of different language when we talk about prevention. So I changed it up a little bit. I want to talk about a couple different frameworks, some different strategies, how it's really kind of all the same in this work, and then also talk about how we unify our prevention specialists, our workforce, our communities, to continue to do the great work that we're doing in the state of Oregon. So okay, there we go. So our guide for today, I want to start by getting grounded in a definition of prevention. We're going to talk a little bit about who's in the room here. Like our representative Noyce, I'm going to ask you to raise your hand or maybe stand up a little bit to get those juices flowing. It is Monday morning, and you've been sitting now for an hour, and I know how that can be. It can be exhausting. We're going to talk about the frameworks and all the strategies, what all that is, and then I'm going to give an opportunity to unify our work and ask you to join the Oregon Coalition of Prevention Professionals if you're interested. So, the Oregon Coalition of Prevention Professionals has a definition of prevention. We focus predominantly on primary prevention. So up here you can see who's seen Kaplan's model of primary, secondary, and tertiary prevention. A few hands, okay. I expect the next one to have more. But when we talk about primary prevention, we're talking about interventions or strategies or things that are done before the onset of a risky behavior, before the use of any substance ever, right? We talk about secondary, or we're also talking about promoting those protective factors and reducing the risk factors that deter participation in any of those risky behaviors. This is for not just substance use, it's for problem gambling, it's for mental health, it's looking at how do we create healthy environments. We'll get more into the details of this. And then when we talk about tertiary, the smallest little section at the top of the triangle, we're talking about providing screening and referral to treatment in order to slow a progression or stop the progression of a risky behavior. So in the primary prevention world in which I work, this is things like maybe a DUI class, right? So somebody gets a DUII, and it can be for a number of reasons. Somebody who gets a DUII may have some sort of use disorder already, but they also may have made a mistake, right? They could have gotten behind the wheel and mixed up some cold medicine and one alcoholic beverage, right, as an adult. There's lots of different reasons why someone can get that. So, thinking about it from that way. This model, I assume more of you are familiar with. Is anybody familiar with the Institute of Medicine's Continuum of Care model? Right? This is where we talk more about treatment as well and recovery supports. So when we talk about primary prevention, we're talking about that yellow promotion and green prevention. So we're a really big part of the continuum of care model. A couple things to highlight. That indicated section, just the last part of that green section, that's where the tertiary prevention from the last slide would be. The promotion and up through the universal, that would be the big primary section. That makes sense, right? Where a lot of our efforts that I work in are moved forward. Health promotion also goes all along the bottom. So health promotion is important for our entire system of care. Right? When folks are seeking treatment services, when they're in recovery, it's especially important that we're putting in health promotion factors so that folks can continue to build and succeed, right? And this can look really confusing in the prevention landscape. And I'm going to give you an example, right? I can teach a financial literacy class to a group of high schoolers, and it can be problem gambling prevention that's universal. I can take that same curriculum and take it to a group in recovery from problem gambling, and it's health promotion, but it's no longer primary prevention because those individuals who are receiving the curriculum may already be in recovery or are being treated for a use disorder. Same curriculum, different population means it changes our definition a little bit. And that's one of the reasons why prevention gets very confusing for folks. I am also going to call out here, I borrowed this parable from last year's symposium. Who was here last year? Oh, a lot of you, that's great. So if you were here in the afternoon, you may remember that a couple wonderful folks, Jill and Shannon, presented on OHA's suicide prevention strategy and response. And they talked about the river parable. And I'm not going to go through all of that. There's a wonderful recording online. From the recording, I'll let them speak about it. But essentially, primary prevention is the work that's at the headwaters of the river or at the bridge that is stopping folks from getting in the river that is causing them troubles down the line. Right? So if you're more vocal. This is a great presentation from the suicide prevention team around all of their different interventions and strategies for suicide prevention. When you look at the primary prevention at the bridge and beyond, or before the bridge, at the headwaters, you'll see curriculums like Sources of Strength, which is a healthy, pro-social, resiliency-building curriculum in schools for youth. It has very little to do with suicide or assessing suicide risk. I don't even know if that comes up. Right? It's all about pro-social values, teaching kids coping skills, healthy mental health boundaries. There's also youth mental health first aid. So youth can get trained in this, and adults can get trained in it. It's mental health first aid for adults as well. We have lots of different varieties of that. And that training is a little bit more specific to the warning flags, the listening for the concern and expressing that concern to get someone into services before there's a crisis, ideally, right? And then how to intervene if there is a crisis, how to help a person get to the folks who can provide the crisis response, right? And then as you continue down the line, you'll see the 988 line, you'll see the CALM, which is the access to lethal means trainings, lots of other ways to intervene, become one of those interveners, right? So again, I like to go back to this version, the headwaters and the bridge are the yellow and green section, and then everything else is our treatment, maintenance, recovery supports, right? It's one thing I'll say that I don't like about this particular image is that it doesn't say the word recovery, it says maintenance. All right, we're gonna talk a little bit about who's in the room. And before I tell you a little bit about my story, which I'll go through, it's a little bit convoluted, I wanna know who here works in treatment with youth, right? Thank you for being here. I really appreciate you being here, and it's really important because it's important for prevention and treatment to understand each other's language and to understand where we start and stop and continue to work together, right? That's critical. Who here is an educator with youth? All right, a few hands, excellent. In the back, I like it. All right. How about folks who work with youth outside of a school system, an after-school provider, a mentor, a coach, life skills, Boy Scouts, Girl Scouts, those kinds of things. All right, quite a few of us, right, working with youth in lots of different areas. How about healthcare? Anybody in the healthcare industry? All right, quite a few. How about the business community? Anybody here work with youth in business? No? All right, I didn't think so. How about parents? All right, a lot of us are parents. I'm gonna say in primary prevention, that's the most important role, right? That's the biggest one. All of these roles have an element of primary prevention. Anybody here like a prevention specialist or a coordinator? Excellent. I see a few of my people, okay. How about a certified prevention specialist? Nice, excellent. All right, and then lastly, my coalition directors. We're gonna talk about coalitions in this framework as well. I know I got at least one over there. All right, very important. So here's my story, just so you know who I am a little bit in the room. It was a little bit in my bio. Again, the picture up at the top left, that's me with my dad. I put a picture of my dad there because my dad is a big part of why I'm in this work. Big part of why I didn't want to be in this work in the beginning, and I just kind of fell into this and ended up in it. And I think one of the reasons I'm good at it is because I get it, because I grew up with it. My father lived with both behavioral health and mental health challenges his entire life. He went undiagnosed with mental health challenges until he was about 60, and he only lived for about 8 years after that. He was houseless many times. I struggled a lot. There were a lot of risk and protective factors in my story. That's why it's a bit of a squiggly line. I was very fortunate, incredibly lucky to be able to go to school. Sorry, I'm on U of O's campus, but I gotta say go Beefs, because that's where I graduated from. When I went to Oregon State University, I had a plan. I was gonna save the salmon. I wanted to be a fisheries and wildlife biologist. That's what I got my degree in. I'm really short. Waders do not fit me well. I started halfway through my career, and it was a fall semester, and I had to go do the river walks. So I had to get the boots on, I had to walk half a mile, I had to shock the fish to do fish counts, and I thought, this is not what I want to do. I am not good at this. I'm not cut out for this at all. So I shifted my narrative a little bit, and I went into environmental education. I really love talking about salmon. I really love talking about our environment. And after I graduated, I started working as a camp counselor, an environmental educator in Portland, and I ran a summer camp called PEEPS for a couple years, Portland Environmental Engagement Program. When that ended, I decided to go back to school, and I got a degree in program management. And I landed a job at Volunteers of America. It was very small. It was about 10 hours a week, and it was on after-school programming. One of my former college roommates actually had the job before me, and she said, "Look, we're doing this weird thing." You know, she had been in public health in college, and so she had run health curriculums like STARS. Anybody remember STARS? Students today aren't ready for sex. Then great, right? Yeah. So she was hired to teach kids in low-income housing prevention, but she'd only ever been in school settings. Her counterpart was from the foster care system and reunifying families that were involved in that. But neither one of them had worked with kids really in a community environment without their parents around. So I got hired to help kind of figure out how we run after-school programs, and that's how I ended up at VOA. I was there for quite a while, 7.5 years, I think, and lo and behold, our funding came from our local prevention dollars in our county. So when OHA put in the OARs, the administrative rules, that you had to become a certified prevention specialist if you worked 20 hours or more, guess who became a certified prevention specialist? And I thought, man, I didn't want to have anything to do with drugs and alcohol. I moved out of my dad's house at 16. I didn't really move it. There was nowhere to go, right? He was out on the street. So I really avoided this because I didn't want to be, and I didn't want to have to talk about it at all. But lo and behold, here I was. And I loved it because really we weren't talking about drugs and alcohol. We were building up strong kids. We were strengthening their supports. I just loved the picture of the backpacking because I got to go backpacking in the woods for 7 days with 5 young women and 5 women who were like nature guides, so as a form of our prevention system. From VOA, I have gone on to Multnomah County, and that's where I am now. I became a prevention specialist at the county level, and my responsibility was to create the strategy of what do we do with our prevention dollars within our county. That was my role for quite a while before I became a supervisor. As a part of that role, I also became our Big Village Coalition Director. I asked if we had coalition directors, and I know we only have 1 currently in the room. Well, 2 if you count me. But are anyone connected with their coalitions in their community? Any drug-free community coalitions? Couple? Okay, that's great. There are coalitions in almost every community in Oregon. They're somewhat hard to find. There's not a ton of them that are funded. We'll talk more about that in a minute. But they're a really important part of primary prevention. And then one thing I forgot to mention is, again, like I asked who the parents were in the room. When I was at VOA about 15 years ago, I became a step-parent. And so those are my grown kids, but they were all young or preteens when I started. And so one of my biggest roles in primary prevention is working with teenagers in my own home and talking with them about the importance of substances and their own mental health challenges. All right, I'm finally getting to the frameworks. The strategic prevention framework, like I said, is what Bernardino asked me to talk about. So the strategic prevention framework really guides a lot of primary prevention practitioners' work. It's really important. You start with assessing needs. So that's collecting your data. What are the problems in your community? How do you know they are the problems? You assess what resources you have to address those problems, what readiness your community has. So what's really interesting, I can share a little bit in our community. Fentanyl, and particularly meth-laced fentanyl, like Representative Noyce mentioned, is a big issue in our community. Our coalition, the Big Village Coalition, has funding specifically dedicated to youth alcohol and cannabis use. But we were able to shift out some of our strategies to include opioid work and fentanyl work because we know that's what our community is itching for. It's what our media is talking about. Our data doesn't show that a lot of our kids are using that, but the ones that are using it are really affected, right? And so we are able to include that into our work because we have data and we're constantly assessing our needs. And quite frankly, if we go to schools and we say, we want to talk to you about underage drinking, and they say, we want to know about fentanyl, they're not going to let us in the door, right? So we have to work with what our community both wants and needs. From assessing your needs, you move into building capacity. Building capacity is all kinds of things. It's about figuring out who in your community is already doing the work. It's about identifying how you can do more with less, because that's always a question. right? It's getting funding to help support some of this work. It's building that out. Then you start your planning of your strategies. We're going to talk about the different types of strategies and what looks comprehensive in a minute. But you start to plan we figured out what the problem is. We figured out what we have already and what we need to address this problem. How do we put plan into action? Once you put your plan into action, that's when you're starting to implement your strategies, right? And this looks very, you go back to assessing and implementing. One thing I didn't say about this is a circle for a reason. It's not linear. You don't start with assessment, end with evaluation, and you're done. You're constantly assessing and building capacity and planning as you go. So you implement your strategies, and you're starting to evaluate them from day one, right? You're evaluating, is this effective? Are our numbers going down? Are what we're addressing working? How is that? We've decided to create a campaign. How is it landing with our community? Is it working? Do people like it? Do people not like it? Is it offensive? Should we move it? Should we change it? If we think about what Representative Noyce said about ballot measure 110, that's, again, SPIF was in that, right? We created a plan. We started. Maybe we worked really hard. We got things started, and maybe some other things happened and intervened, and now we're having to readdress and reassess what our needs are and how we continue to evolve and solve this problem without going backwards, right? I like to put the other framework. Is anyone here from public health or have a public health background? One couple? Yeah, excellent. Okay. Beautiful. Yeah. So the other framework over here is the evidence-based public health framework. I like it because the image looks very similar. And guess what? It is. A lot of times, especially I see new prevention specialists in their roles, and we get thrown questions like, are you using the SPIF? Where is your evidence-based intervention? Which evidence-based strategy are you going to use? Did you do the right assessment? There's all these questions that come throwing at us, and it gets a little bit overwhelming from time to time. But again, what I like about this evidence-based one, I know you can't read it from up there because it's pretty small, or maybe you can a little bit. You're assessing the community. You're looking at the quality of the issue. You're developing an initial problem statement. You're doing some literature. What else has been done to solve this problem? You're learning from what's been done in the past. You're putting into place and prioritizing your program or your policy initiative. You're action planning. You're evaluating the program or the policy, and then you're disseminating the evidence. You're always constantly talking about what you did, right? Disseminating how you know it's working. Or not working to that effect, right? Because if we know something's not working, we can try something else. So I talked about the SPIF framework a little bit. By the way, there's a training called SAPST, the SPIF Applied Prevention Skills Training. It's 40 hours. There's a lot more to the SPIF, but I wanted to kind of try and keep it as brief as possible because I couldn't do it in 40 minutes, even if I was just talking about that. One of the things in the assessment phase that we talk about is our risk and protective factors. And for those of you in the treatment world, you know about this well, right? Folks are very often brought into their disorders by their environment, right? There's factors that affect everybody. I mentioned that I was very lucky I got to college, right? I have a history of use disorders and mental health illness on my dad's side of my family. I'm also very lucky that my mom's side of my family doesn't. So in terms of genetics, I'm kind of lucky, right? It was kind of a 50-50. Not really, but that's genetics, right? I'm not a geneticist. I lived with my father. My mother passed when I was very young, so I ended up living with my father as a child. But I also spent weekends, holidays, and summers with my mom's family. My mom's family were all college educated. So from the time that I started, I think I introduced myself as a kindergartner and said I was going to be a beaver. So I had a lot of luck and a lot of guidance from that side of my family, right? I also had the fortune, I guess, I don't know how to say this part, but my father ended up in prison the year that I was graduating from high school. It was also the first year the FAFSA went online, completely digital. So I'm starting my FAFSA online, and it says mother's income, $0. She deceased when I was 6. Father's income, $0 for the last tax year he was in prison. FAFSA would not let me move forward. There was like, there's no way in heck you didn't make any money. Your family didn't make any money to support you. And of course that's not true. I was living with my grandparents. I was fully supported. But FAFSA the federal government couldn't figure that part out yet, right? And I know that's a lot of different people's stories. I had a grandmother who was retired who went to my school counseling office and sat there until they made phone calls, they did all kinds of things. They figured out that I could be an independent. So then I got college scholarships and all kinds of offerings as if I was a very low-income person, even though my grandparents had some income, but they weren't considered my legal guardians. Right? So again, when I say I was fortunate, I was very fortunate. So again, I talk a lot about my risk and protective factors. When we look at risk and protective factors, it's not just about the individual, it's about the family. It's also what services are available. So when we think about our state, across our state we have different services. In the Portland area, there's a lot of things. There's a lot of services. We may still have lots of wait times, we may still not have enough beds, we may still be in need of things, but we actually have them in place. We don't have to drive 3 hours to the neighboring city to get them, right? We also have more likely to have services in multiple languages, not also an option in all of our different rural communities. There's also life events, right? We put that in there too, is like, we have, how do we build resiliency in our life? And then societal. There's a lot of things as a white, cisgender female that I have a lot of privileges and protective factors that a lot of individuals don't. I don't face the same discriminations that other folks do, right? I have inclusion in different things that other folks don't. So just thinking about all of that as risk and protective factors, that's all prevention as well, right? And impact whether or not we use or not use substances. It impacts whether or not we could potentially develop a mental health disorder, all of that. Okay, so we're getting into different strategies. The next 2 slides are going to be somewhat similar. So CSAP, the Center for Substance Abuse Prevention, which is a SAMHSA identified area, has 6 core principles, strategies or processes to use. I bring up CSAP because your local prevention providers have to develop strategies within these principles. It's part of our grants, it's part of our work plans, right? So that starts with information dissemination. Information dissemination is one-way communication. That's our health campaigns, right? That's our, One Pill Can Kill. That's our Rethink the Drink, those types of campaigns that are out there in our community a lot. Prevention education, that's 2-way. So that's our curriculum in our health classes. That's our sources of strength that I mentioned earlier. There's lots of substance use prevention curriculums out there as well. We also have alternative activities. I mentioned earlier, I asked who's a mentor, a camp counselor, maybe a faith-based youth pastor. All of those, having things for kids or youth, shouldn't say kids, youth to do to keep them busy. Busyness is a deterrent to substance use. So when we think about prevention, that's a really important piece. Like I mentioned, Portland has a lot of services. In our primary prevention dollars, I really don't have to invest in alternative activities because there's already so much in our community. But a rural community may not have those options, so their prevention dollars may go to providing after-school care. Now I mentioned Volunteers of America. I was an after-school program coordinator. That position was funded by our primary prevention because it was for a more at-risk population. It was, it was for our low-income and youth of color specifically. We were working with our housing provider to do prevention work in those communities. I didn't realize that at the time. I thought it was universal. It was just kids are kids, families are families. But then I kind of came up to this level of prevention, and I thought, oh, now I see that strategy. Does that make sense? We also have problem identification and referral. This is that tertiary part of our prevention scale, right? That's our SBIRT, screening to treatment. That's why working with treatment providers in prevention is so important. We need to know about what resources as prevention professionals there are so that when we find someone that is experiencing warning signs or is in crisis, we can help them as quickly as possible. We have our environmental approaches. These are our policies, our laws, our norms. How do we improve things for the environment so that the environment is better so folks aren't falling into the river? Right? And then our community-based processes. Those are our coalitions. That's how are we involving our community in doing this work. This slide has a few of the same images. Has anyone heard of CADCA? All right, a few of you, excellent. I'm not gonna try and say CADCA's name because they changed it. I believe it's Community Building Advocacy Focused Data Driven Coalition. See, building is in there twice, and I know that's wrong. Association. They're an association that is all about focusing on supporting coalitions across the nation. What I love about coalition work is, like I said, it's really community-driven. We'll get to that in the next slide. They have their own 7 strategies for change, which are very similar to the CSAP, but I like them because they kind of pull out some of the environmental stuff. Your individual change, you're providing information, pretty much the same. You're building skills, that's the prevention education. It's also building skills of community members. It's doing exactly what I'm doing right now in terms of trying to teach folks about prevention and about this work. Providing support, sorry I got cut off there, is again your alternatives. How do we provide support to our community? It's not just about alternative activities for youth, it's support groups for parents. Parenting is really hard. How do we support our our parents in our community to do this work so that we aren't relying on substances? Then the environmental change is around enhancing access and reducing barriers. What I like about that is it's translating materials. It's co-translating or creating things for all folks in our community, because not everybody speaks one language. We're not monolithic society. It's changing consequences. So this is where it comes to, like, we have laws and norms around serving under 21, serving minors, right? We have rules and regulations. This is the Parents Who Host Lose the Most campaign. It's about educating parents on, we have laws in Oregon that you can serve your minor in your home. That does not mean you can serve all minors in your home. It doesn't mean that you can serve your minor out of your home, right? It gets a little confusing. So helping parents understand what the actual rules are. Physical design is changing our physical spaces in our community that everyone uses. So I think a lot about tobacco is sold behind counters, behind locked boxes, right? So that no one can get access, young people particularly. And then again, modifying and changing policy, which all of these environmental changes are kind of pieced out of the CSAP strategies. So just a touch more on coalition work, because it's so important to this primary prevention space, and I think it gets left out a lot, is that coalitions are formed. In order to receive funding from the federal government to do substance use prevention work as a coalition, you have to have at least 12 sectors. So that's all of these little sections around the local problems require local solutions. I also like to say, nothing about us without us, right? So if you're gonna work on youth prevention work, you better have youth as a part of your decision-making alliance. You're gonna have the media, hopefully, there. You're gonna have businesses, because if you're gonna be working on a policy that impacts businesses' ability to sell products, you better have them at the table so you understand what their needs are too, right? You want, again, like I mentioned, treatment. You want those substance abuse organizations, it's listed here. You want your treatment organizations, your recovery organizations, or individuals with lived experience to help inform what strategies you move forward. Because again, you want to educate, like, you don't want to go backwards, right? This goes back to the public health model where we're disseminating what we've learned. We don't want to retry something, recreate something. Folks remember DARE? Right? DARE didn't work, right? I've seen a lot of curriculums come out of this fentanyl movement that are very similar to DARE, right? Because we're like, if we just tell the people that it'll kill them, they won't do it. That's not what our data tells us. That's not what our history tells us. So I just threw a lot at you, and I'm just about done. I think these are all the core frameworks that I use on a day-to-day basis in my work, and it's a lot to learn especially when I was relatively new to the field. So we have this group called the Oregon Coalition of Prevention Professionals, and we are a budding new nonprofit. This is our leadership team. Luis and Bernardino have both been on the leadership team, or are on the leadership team. As I mentioned, I'm currently the co-chair or the chairperson. I think we have to vote in December. I may not be the chairperson very much longer. I can't remember what our bylaws state. I may need to move off. But we have folks, we've been working to get leadership team members from across the state. We have quite a few in the Valley right now, but one of our goals is to increase the amount we have statewide or rural. What we do, we are really focused on supporting prevention, primary prevention in Oregon. We do that in a few different ways, primarily through 3 committees. The first one is our Connections Committee. Prevention practitioners, sometimes there's just one person in a county, especially our smaller counties. You might be doing substance use prevention, problem gambling prevention, tobacco prevention. You might have all those hats that you're wearing at once. It can be really isolating if you work in a behavioral health division and maybe you're the only prevention person and everybody else is treatment, right? You're a really critical part of the core, but nobody else is doing similar work, right? The Connections Committee is all about how do we connect our folks across our state, better share what's working, share what campaigns we're doing. Maybe if everybody was doing a Rethink the Drink campaign, the state puts it out and like multiple counties adopt the campaign at the same time, maybe more people are gonna see it, right? It's gonna have a bigger impact. So thinking about how we better connect our work. The Learning Committee is about educating and the professional development of our workforce. So I asked if folks were CPSs, and I had a few in the room. There is a certification that MACBO offers, the Certified Prevention Specialist Training. OCPP just received almost $500,000 to provide a cohort where we're going to ideally train and prepare to certify 100 individuals for free in the next 2 years. That's a big lift, but we're gonna do it. We've got training, we've already done a pilot of this. We're gonna work through this process because learning those frameworks and how we do this work day in, day out, it's a lot, it's really hard. And then we have our Policy Analysis and Education Committee. One of the things that's a real struggle for our workforce is that many of us, the dollars that pay for our FTE are federal dollars. So we're limited in how much advocacy and education we feel we can do. And there's been times in our history recently where folks have lost jobs because they were just educating the community on maybe the negative impacts of things like legalizing cannabis use. And they lost their job because we were too afraid it was advocacy, and with federal dollars we can't provide any advocacy. So this committee is really focused on making sure we have a voice at the table and that we, as our folks working in the world, know what the line is. Where's the line? What can I do? What can't I do? How do I educate my community on both sides of a potential political issue? So, there's a couple ways that you can get involved with us if you're interested. The first is we have a Facebook group, the Super Preventionist Facebook group. You have to go to Facebook, you have to search the Super Preventionists, those little capes, that's our profile image, so hopefully it'll look familiar. And then we are about to launch a recruitment campaign for OCPP. I said we're new, we're launching. This QR code will get you just to a Google form where you can put in your name and email address, and we will email you when we're ready. Membership will be $65 to join our little organization. Oregon Council on Behavioral Health has been an amazing partner and is our fiscal sponsor right now. So we're trying to build up similar to OCBH for our state. And that's what I have today. Thank you.
We have time for a few questions if anyone wants to raise their hand.
So you mentioned having some funding for the CPS training. How are you recruiting people for that? Or do they have to be employed somewhere specific, or is it like a thing you can register for?
Well, if you sign up on the QR code, you don't necessarily need to become a member to get the recruitment. Basically what we're gonna do, it's a Google form, I'm gonna collect your email addresses. We'll send you information, but there's also a little section, a question that asks if you want other communications from us. And when we have our cohort ready to go, which will probably be in January of 2020, sometime between January and July, let's be real, of 2025, we'll send those out and recruitment processes will happen. You do not need to be a member of OCPP to join currently.
With that QR code?
With that QR code, yep.
Thank you.
Hi, so I just had a question, how, it's pertaining to like how you would handle a situation. So I am a parent committee president, and we were recently notified that, I also work for we work with prevention. So one of the things we were told was that in the school, if a student were to be caught with like a tobacco, like vape, they wouldn't get in trouble or anything for it. How would you handle that?
Interesting. I think the first thing I would do is get in contact with whoever at your school is helping to develop those policies, to better understand the policy. Because it would surprise me that nothing would happen. It also depends on age, right? Because we had tobacco 21. Tobacco products and other substances have historically been separate. And I know it's really confused our schools, especially now with the vape devices that have been created and the fact that you can vape multiple different substances, including not either tobacco or cannabis. And so their reaction to vaping devices has been really different, right? And so a lot of schools I know in Portland, a lot of our schools are working on restorative justice practices and making sure that we're not, penalizing or sending kids away from the school, because that doesn't do them any good either, right? Back in the day, sometimes policies were, we're going to take these away from you, especially before we had Tobacco 21. We're going to take these away from you, but then your parents can come pick them up at the end of the day, right? We even saw that in some of our schools in my county, not Portland, for those that are in Portland, that with cannabis, same thing. Cannabis was brought to school by students. Parents would call home. Cannabis was just legalized. Parents would say, that's my cannabis. I want it back. So they would return it to the parents, right? When previously it was an illegal substance, so they would just hand it over. I think, so my first step is to connect with the school and figure out really what is at the heart of the crux of the issue. And then start educating, right? If it is a policy where there isn't a whole lot, you're gonna need to start figuring out your readiness and start talking with your schools, start talking with your students. What's the understanding of the current policy? I'm gonna give a shout out to somebody in the crowd, Mary Crow, who works with Portland Public Schools. We did an assessment and worked with some students during the pandemic and learned that students didn't understand. There was a whole new policy in PPS, but students and teachers didn't necessarily understand the difference in the policy. So we got some students together, and they created a training video for teachers to take at the beginning of the school year, where teachers got to learn directly from the students what the new policy stated and what was important. And then also how to have fruitful conversations with students without shutting them down, right? If they found themselves in a situation. That would be my first guess. And then if you have more questions, I would definitely come to me at lunch and I can send you to my guru, Mary, because she's going to know more than I do.
Thank you. We have room for one more question. If any, I see a hand over, Jim.
It's not really a question, it's more of a statement, sort of referencing both what Representative Nose was talking about and what you're talking about. And this is kind of obvious, but I'm going to say it anyway. So my name is Jenny, and I work for Washington County, and I'm privileged to be able to actually go into health classes all the time and talk to students. And I've talked to hundreds and hundreds of students, and I ask them what they're worried about, what's going on with them. And they often will tell me, I'm worried about the economy. I'm hopeless because our planet is dying. They tell me I can't afford the things that would care for my mental health, like art supplies. So what I have to say is funding the arts is prevention, and it's solving mental health issues. Funding affordable housing and maintaining that affordable housing in healthy ways is prevention. Funding the things that help families be strong and educate and support parents in our communities is prevention. And this is where we have to start and where we can end. And our kids will be better if we can put our money and our efforts and our time into all of those fundamental pieces of our society. If they can't afford some basic art supplies, if they can't afford a safe place to live, if our communities are suffering and our parents can't care for their children and take care of their own health and mental health, then our kids are suffering, and that's where we're at. And it's a tragic situation that we found ourselves, and I think we can figure out ways to dig out of this, but it's going to take a lot of work, and it's definitely going to take money. And that's just what I have to say. Thank you.
Thanks, Jenny.
Thank you.